Well, before I get started, I'm going to give you my reminder for the second time today. Silent mode. It's very distracting to speakers when your phone goes off during your presentation. Our speaker today is Dr. Jane MacPherson, who's an expert on palliative care. That will be her topic. Jane is a graduate of Michigan State University and Medical School, 1988. Did a residency at St. Lawrence Hospital in Lansing. She's board certified in family practice and hospice and palliative care. She has 20 years experience in working in Salt Lake City, patients suffering from congestive heart failure. After that, she has 13 more years experience collaborating with oncology in Salt Lake City. Jane moved to Holland in 2021. 2020.
Yeah.
What a year.
Yeah, I know. It's a great time to come.
And she is here to share her knowledge and wisdom with us. So please welcome Jane MacPherson.
Oh, thank you. So, and I am a HAS member, so that's one of the reasons I'm here. I was asked, and I haven't presented in a long time, so bear with me. Thank you for the introduction, John. And this is a topic that I was happy to see people signed up for, and I guess many more people are signed up remotely, which I kind of understand. Some people get a little squeamish about this topic, but it's a really important field of medicine and a field for you to understand so that you can benefit from all the services that are provided. So I'm going to talk about palliative care, and to me, that means providing the best supportive care. And the goals of this presentation, as you can see up there, are to discuss the evolution of medicine very briefly, or I'd have to do like 10 sessions, but from kind of in my lifetime and a little bit before, because a lot has changed in the practice of medicine since the 1960s, I would say. I'm going to define palliative care. I'm going to briefly contrast palliative care and hospice because they aren't really synonymous. A lot of people think they are, but they aren't. And hopefully I'll help enlighten you on that if you had that misconception. And I'm going to describe at least 3 categories of people, actually a few more, that might particularly benefit from palliative medicine, and describe the role of the palliative care team, who they are, what they do, how they support patients and families during the course of their illness, and then tips on when and how to access palliative care. Since I never practiced palliative medicine in this community, I had to do some homework with what's around here. And it's a little different than my experience in Utah, where I was for many, many years. And that, by the way, is not unusual, that the practice of medicine varies from place to place. Not that that's bad, it's just different. All right, now, okay. And why does this discussion matter? So I think it matters, especially in a group like this. Have you or someone you've loved been diagnosed with a potentially life-threatening illness? Probably everybody in this room would say yes to that in some fashion. I mean, I was blessed as a young person to go almost, well, until I became a physician, without having any sort of tragedy in my life. My grandparents lived to be 100. I mean, I just didn't lose anybody. So it was like, but then you practice medicine and you go, oh my gosh. Well, and how did that make you feel when you got that diagnosis, or that family member got that diagnosis? I think for a lot of people, they feel like this. Like, oh my gosh, this is some sort of, I've been marked. I have this sentence, I'm doomed. And, you know, that's a normal reaction. And people even get it when you tell them that they have diabetes, which now we know we can really manage for a very long time. But, you know, when you're talking about even more serious illnesses like cancer or Parkinson's, or, you know, neuromuscular degenerative disorders or heart failure, people get pretty discombobulated by that. And a lot of that, I think, is because they had this kind of life story they were writing, and somebody just ripped their book in half, you know, and they have to now think about rewriting a whole different life story, and they don't know what that looks like. And so it's a frightening time. And so for years, when people had a diagnosis, like we were referring to, usually you would see a specialist with the focus on a curative active disease management strategy. And doctors were really focused on this with more a goal of cure, or if they couldn't cure, at least delaying the progression of the disease. In the past, I think we looked, because we had this disease model, we were really focused more on the disease than the total person, their experience of that illness. And so the emphasis, and this was really when I was training too. So this is, I mean, not that many years ago since I graduated in 1988. I went to Michigan State. They were considered sort of an enlightened medical school. They were into the biopsychosocial model of medicine, which was really novel. A lot of other universities, medical schools were teaching this disease model of care. And so in that model, the emphasis is really on symptoms and signs as clues to illness. And not so much that it's anything for the doctor to be particularly concerned about for your benefit, but it's a clue to him or her what's going on with you. And so we even had a period early in my professional career where if people had abdominal pain from whatever, and we were worried it was appendicitis, we would never treat the pain. I mean, they could be writhing on a stretcher, just miserable. And we're going, well, we can't treat that pain because we got to know it's appendicitis before we do. I mean, thankfully, we don't put people through that anymore. But now that's a lot to do with the fact that we have diagnostic tests that we can use to determine what's wrong with people. We have markers for the adequacy of our disease management, which might be labs or radiology. So we have lots of other ways, and we could probably attend more to patients' symptom management. And again, I don't mean to disparage the practice of medicine or doctors because I'm part of that profession, but I think there was a time, and you know, I can remember my grandparents. I mean, there was sort of this Marcus Welby model of medical care where the doctor said, "This is what you have. This is what you're going to do. And you better do it if you want to be okay." And, you know, aye, sir, we'll do that. Those times are really changing, and they've super accelerated with the internet. Now patients come in and they really have a lot to ask, and they want to negotiate, and that's all good, but it's a different world. But back then we were disease focused, and not so much anything else. So my next kind of train of thought was, well, how did your treatment go, or for your loved one go? Was their quality of life decent during this process of disease management? Did you ever feel overwhelmed by the process? My guess is yes, because most people do. When people have really serious illness, they're really sick. And even as a caregiver, that's hard because you don't want to see your loved one suffer. There's a lot of time demands, getting to from doctors, everything that goes with that. And then did the treatment work? And if it didn't, then what? And this was a strange gap that actually existed in medicine in the it was still kind of going on in the 1980s, but for sure in the 1960s, there's this big gap in care at the end of life. People died in the hospital. In fact, I can to this day remember my grandpa talking about two things: his bowels, and the second thing was he didn't ever want to go to the hospital because people died there. And the irony of that is my father was a doctor, a surgeon. So it was a really strange thing to hear from my grandpa about that. But anyway, so if you were being treated, and you didn't get better, and you were getting worse, actually, and the doctor really couldn't do anything for you in the classic sense of the treat was ineffective, you ended up in the hospital where in fact you probably die, or you went home, and if you were really lucky, you had a small town doc who would make house calls that would give you occasional shots of morphine and hold your hand and hold the hand of your family. But there was no organized system for providing end-of-life care. So along came Dame Cicely Saunders, who is really the founder of modern day hospice. She wanted to be a doctor from a young age, but her parents forbade her. So she studied philosophy and ethics and religion because that's what her parents want her to do. But then World War II started unfolding, and she actually then became a nurse against her parents' wishes. And then she became a social worker. And finally, she went on and got her medical degree. And from this really broad perspective, and I can't tell you, I mean, being a nurse and a social worker and a doctor is like a trifecta in my mind. I'm only one thing. That's just amazing to have all of those degrees under your belt and all that experience, really. So from this broad perspective, she actually started attacking the prevailing medical ethic that patients must be cured, and not curing the patient was a sign of failure. And we really believe that. I mean, I still in, even in 2002, I had doctors telling me I don't do death and dying. And that was a cardiologist. And I'm thinking, man, you've been really lucky. I don't know. So, people not recovering or having disease progression or people dying is not a sign of failure on the part of the doctor, and certainly not on the part of the patient. But I think it left patients in that terribly uncomfortable way and position. And she felt also that it was unacceptable to lie to patients about their prognosis. And this still happens to this day, not so much in the United States, but some cultures are really opposed to having honest discussions with patients and families about their loved one's health situation, particularly Middle Eastern cultures. You always have to talk to the man in charge of the family, and he may or may not share. So you do have to accept that, but she didn't accept that. And that did impact the rest of medical practice. She also advocated for effective pain management and symptom management for all patients, but especially for those dying. And she wanted those treatments to be evidence-based. So she really unleashed a world of research into end-of-life care and management of the sick and dying. And she actually insisted too that patients that were dying be treated with dignity, compassion, and respect, something that was sort of lacking in her mind. She was one of the early introducers of the concept of total pain, which basically means that total pain is beyond just the physical symptom. There's an emotional, social, and spiritual dimension. And I think maybe just in a kind of rudimentary way, has anybody in this room ever fallen down? I have. Yeah, okay. And you fall down and you think, oh gosh, did I break a hip? And then you're laying there and you go, yeah, it kind of hurts. And then you start thinking, well, what if I did break my hip? Then what? I was supposed to go on this trip, or I need to get my husband, and your mind, I mean, that's fear. That's not just the pain, that's fear going along with it, and sort of the social suffering. And then you get up and you start walking around, you limp a little bit and it's better. And you think, I didn't break my hip. But can you imagine though, if you have cancer and you've been treated and then you start to have pain, then the first thing you might think, and often is the first thing a cancer patient would think, is that pain my cancer back? Or is that pain my cancer growing? Very distressing symptom. And it has a lot of social impact and even spiritual dimensions of impact. And we'll get into that. All these things add to a patient's sense of distress or suffering, which I use distress and suffering sort of synonymously. And she felt that all the contributors to pain needed to be addressed in order to relieve the patient's suffering. And she felt like this was especially important for people nearing the end of life, who she probably felt abandoned by the medical establishment system, because they either were told that they either had the option of dying at hospitals or dying at home, and probably never had any contact with their treating physician or had minimal contact with them. And she also identified that it really was a multidisciplinary approach, which certainly is true because a doctor can't wear all those hats. And she knew that from her previous background. And so in the absence of a healthcare system prepared to address these issues, she developed the first hospice, which was St. Christopher's Hospice in London in 1967. And she had all of these elements. Interestingly, a sidebar, but she was an agnostic when she started doing this. But quickly through actually, I don't know what she had for Polish people, but she had 2 Polish patients, and she was really moved by their spiritual approach and outlook on life. And that really actually converted her to a believer. And she ultimately ended up marrying a 3rd Polish guy. So I thought, oh, Poland has done some good things. I might actually have some Polish heritage. So, and so then came hospice care to the United States. And our first hospice actually was set up in 1974. It was a volunteer hospice in Connecticut. And then in 1983, Medicare actually introduced the hospice Medicare benefit. And it did require, even at that time, there'd be a multidisciplinary approach to care, much like the model in that Dr. Saunders had, when you had to have a chaplain, you had to have a social worker, you had to have the nurse, the doctor. That's actually was my first introduction to hospice. I was assigned to hospice to be a hospice medical director as a committee assignment. And I just volunteered for a committee here. So I hope it doesn't go any farther than just being on the committee here. That was quite an assignment. And it turned out I was grateful for it because it opened a whole new world for me. But the problem with the early hospice benefit that Medicare offered, well, two things, and one is still true. To be on hospice, you have to be foregoing any further disease modifying therapy, which is a big problem it's not a big problem if you've exhausted all therapy, but that's a big leap for a lot of people to take. And the second problem was initially, it was really a hard limit of you couldn't get the benefit for more than 6 months. And this put doctors and hospice teams in a terrible predicament. So we could say, well, we have no more treatment for this disease in terms of disease modification, and hospice is the right service. But if we don't have this prognostication right, it could run out, and then you might have to be on your own for 2 weeks, a month. I mean, it was a terrible thing. So people would be brought on hospice and then discharged and then wait and then maybe brought back on. And when people are on hospice, they actually do a little better. So sometimes it made it really rough to know, and they would live quite a long time, but that would lead sometimes to people actually dying without having hospice benefit. Most hospices, to be truthful with you, would still provide the care. They just would not charge because it was just inhumane to do anything else. And that was my bringing up. I don't know, maybe other places didn't do it that way, but that's how we did. And even though we now had hospice in this country paid for by Medicare since 1983, many physicians were very slow to embrace hospice care. And in fact, I was known, early parts of my career, and probably for a lot of my career, as Dr. Death. I'm going, I am not Dr. Death, not calling me that. I'm Dr. Possibilities. Anyway, so this is how the model changed, how Dr. Saunders changed it. So it's curative disease modifying therapy, and then a tiny little sliver here of died, and then maybe some family bereavement support. So it went from curative to a little more time. This is last weeks of life. In fact, I'm not talking about hospice in any more detail today, but frankly, a lot of people were on hospice for just a few days, and then bereavement. But she was the one that kicked this off. So kudos to her to at least introducing this curative hospice model. And so I've kind of alluded to some of the problems with the curative hospice model. But one of the issues with it is that what happens to those people that aren't really hospice appropriate, treatments for life-limiting illness that could contribute to physical and emotional suffering for patients and caregivers. Who's doing that? Not hospice, probably not the subspecialist. Maybe the primary care doc tries to do it, but and yet the ongoing treatment of the disease, whether it's heart failure or cancer or Parkinson's or whatever, is more effective with time because we're getting better at this disease modifying care. They're living longer with their illness, which means they suffer longer. And even the symptom burden might be becoming greater because every treatment might be more burdensome than the last one and leave you with side effects. So this really kind of was this model still wasn't right. It also added a lot of financial burden through the loss of income. When people are sick, they can't work. Their caregivers sometimes have to quit their jobs to take care of them or cut back. And And the curative model also did not have a multidisciplinary focus. Sure, we all knew how to call social workers and psychologists and things like that, but we didn't know people that knew how to help people have their suffering, have their stress relieved in an easy way. And if you've had a chronic illness or a life-threatening illness, you really don't want to be running off to like 10 more doctor's appointments, right? I mean, you really are kind of up to here with doctors already. So adding a whole bunch more people was sort of not very coordinated and didn't result in good outcomes. And remember, if they were receiving active treatment, which they wanted, they were not eligible for hospice. So they were kind of out of luck. So what do patients with serious illness and life-limiting illness want? Well, they actually wanted the same things that hospice patients wanted. They wanted relief of their pain and their symptoms. They wanted a sense of control and to maintain their dignity. They wanted the burdens on their family relieved as much as possible. They worried about the burdens of the physical, emotional, and financial stress. They wanted to have stronger relationships with their loved ones. Interestingly, and this was from JAMA, they also were worried about prolongation of the dying process, meaning they didn't want to be subjected to futile care, and that's a problem with the curative model because most doctors can always pull one more thing out of their hat. I mean, honestly, we can. It's just crazy. But is that really what the patient wants? And in this study in 1999, the answer was no, that's not what all patients want. Some do, but not all. And so the bottom line is they wanted an improved quality of life for the time they had left. So, and this was not happening. This is a big trial involving a tertiary care teaching hospitals across the United States. It's called the SUPPORT trial, making it easier to say than all that. And it involved 9,000 patients who had life-threatening illnesses, and 50% of them died within 6 months of being admitted to a hospital. So you can tell they were very sick. And half of those patients had moderate to severe pain, even in their last 3 days of life, when it wasn't really a surprise that they were seriously ill and would have lots of pain. But nonetheless, they had severe pain, which would seem fairly unacceptable. And then 38% of those ended up in ICUs, many on vents or in comas, which isn't really quality of life. And some people probably didn't want to have that, but that was how it was done because we didn't want to let people die. And this is kind of an important thing that I think people are hearing about more and more, but 20% of those cases, the family member had to quit their job, and almost 29% reported the loss of a major source of income. And that resulted in almost a third of families losing most of their life savings, which was super tragic, and honestly, I took care of people where they'd second mortgage their house to pay for their medical care. And now they weren't going to live, and nobody can pay either mortgage with no income. And what are we talking, repossession, losing your loved one and having your home repossessed. It was very inhumane. So it was an interesting study. And then another study that I'm going to share is just symptom burden, because people with lots of illnesses have lots of symptoms. So cancer is sort of obvious, but here's 30 to 50% of patients that are undergoing active treatment for their cancer. Maybe don't have metastatic disease, but still 30 to 50% have pain. What's the pain coming from? Their treatment. I mean, treatments cause neuropathies, breast cancer treatments sometimes cause joint pains. They have pain from things that from the treatments they're receiving. And then with advanced cancers, almost 70% have fairly significant pain, not mild pain, moderate to severe pain. And then fatigue is quite common. Almost 89% have pretty significant fatigue. And as the disease advances, it gets worse. 12% have insomnia. 25% of cancer patients have anxiety. Lots of symptom burden there. But here's a big surprise for a lot of people. I'm sure some of you know people with heart failure, but heart failure patients have a plethora of symptoms too, including pain. 78% of heart failure patients have pain. You go, well, are they having chest pain? maybe, but not necessarily. They might have joint pains. They might have leg pain from the swelling. They might have pain because they sit around more. And pain and heart failure is a little tricky to treat because there's a lot of drugs that your cardiologist doesn't want you to take when you're taking all your heart failure meds. Of course, shortness of breath kind of happens, but almost 2/3 suffer from depression, half suffer from insomnia. Surprisingly, loss of appetite is quite common, nausea and vomiting, and almost 1/3. And that's from the heart failure. Or sometimes the treatment, but often the heart failure because of how things congest, constipation. I mean, this is a lot of disease burden, a lot of suffering here, a lot of distress for the patient. And I can promise you the caregiver, because I see a fair number of women in this room, and no woman likes to see her man not eat. And so, there's all this hovering around, eat this, eat that, eat this, eat that. Well, maybe when you were younger, they didn't want you to eat all the time. But when you get older, and when you're children, mothers want you to eat and wives want you to eat. So that's some of these symptoms really bother the caregiver quite a lot. So everybody suffers in this situation. And it's not limited just to cancer, heart failure. Many life-limiting diseases share some of those symptoms, like emphysema, very common, not only to have breathlessness, but anxiety, Parkinson's, a lot of muscle pain from the stiffness and then the falls that sometimes they have. Even people with dementia have symptoms that are often unmanaged because they have a hard time verbalizing their symptom burden. And in fact, a lot of behaviors in dementia are really what we know now are being driven by pain. So if you treat pain, like even though they can't tell you they're in pain, a lot of times you'll see them become more comfortable and less agitated, which is sort of an interesting thing. So what are the barriers to getting this kind of symptom management things you want? Some of them have to do with the complexity of care these days, care being delivered in multiple environments, the siloed nature even of medicine contributes. So you might have a PCP and then subspecialists and hospitals and rehab facilities all involved. And then the more symptoms you have, it can result in more medications, which then results in more drug side effects and drug interactions. And just kind of for the record, if you're on more than 4 different prescriptions, you take more than 4. Well, so if you take 5 or more prescriptions of any drug in a day, you're much more likely to have drug interactions with each drug added. And yet, a lot of times in medicine, you go to see the doctor and they give you a pill for nausea, they give you a pill for pain, they give you a pill for anxiety. It turns out to be an awful lot of pills. And then we're kind of back to the lack of medical focus on addressing quality concerns, communication breakdowns too between the physician and patient. I always go with my husband to his physician, not always, but a lot of times I go with my husband to his physician visits because if the doctor asks him how he is, he's going to say he's fine. And I'm going, you are not fine. You might be fine right in this very moment in time, but I think they mean globally. You've been fine. So it's not anybody's not trying to say, they just don't want to bother the doctor, right? But we're there for that. And even physicians have breakdown between other physicians, especially if they don't agree with what's going on. And physicians in other disciplines can be like 2 ships in the night. So, and oddly, some patients do see suffering as a necessary part of their illness. It seems odd to me, but some cultures actually value that. I had a Buddhist woman I cared for, and she didn't want her pain treated because it was important for her to experience pain because of her belief system. And that may be true in other things. And then just not having a conversation about what are the patient and family goals also makes it challenging. So, and then that resulted in palliative care as a model of healthcare delivery being formed. So this is the World Health Organization's definition of it, and I'll just let you read it. It's a hugely long run-on sentence. I don't see any periods in there until the end. And it does address all the issues in kind of a very, I guess, accessible way. But I'm going to show you some easier definitions to get. And so even before the World Health Organization came out with this, there was the formation of the American Board of Hospice and Palliative Medicine that started in 1995. And they introduced a physician board certification. And so these were kind of happening in parallel. Hospice, then the American Board of Hospice and Palliative Medicine came along. And then the World Health Organization sort of made a global announcement that palliative care should be available all over the world, not just in England, not just, in the United States. So we weren't doing much palliative care at all. So to put it more simply, the two definitions that I think are important to take away here is, what does it mean to palliate? So basically, to palliate is to make a disease or its symptom less severe or unpleasant without removing the cause. So a palliative care doctor isn't treating your disease. They're treating your symptoms related to your disease. And so you're still going to need, if you wish, to see that doctor who's managing your underlying illness so he can disease manage, while the palliative care doctor focuses on helping you feel better. And I asked my former patient, I haven't seen her in a while, but I said, how would you describe palliative care? Because I know she really thought it was a godsend in her life. She had stage 2 breast cancer, but is fine today. She needed surgery, a brief round of chemo. She got some neuropathy from her chemo, and she was on a aromatase inhibitor, which is a hormone modifying drug that cancer patients receive. And she was pretty miserable with that, and came to me. And that's a whole other story, but she was able to get through her treatment. So this is her definition of palliative medicine. Palliative care is a specialized form of medical care focused on relieving the symptoms and distress of serious illness, not the illness itself. She gets 2 points getting that right. And the goal is to improve the quality of life for you and your loved ones, and helps you continue your treatment, which was super important to her because she really didn't want to stop that drug for her breast cancer. She needed to be on it 5 years, and she was miserable. So we worked on a lot of things, and she was able to successfully complete her therapy. And she's disease-free now, so it's been 13 years. So she's probably good. So this changed the model again. So now we have curative and palliative, and you can see early on, not as much need for palliative, and maybe not even as much, more emphasis on curative. But say, for example, you have cancer is an easy one for me to talk about. You have a cancer and they can cut it out and, you're done with it. So you might just stop here. But if you have heart failure, or if you have progressive cancer, then over time, the treatments will continue, but the symptom burdens will become greater and the role for palliative care becomes greater. And then if it happens that you fail all these therapies, and I hate to use that word fail because I said we're not failing anything, but they're not working, let's put it that way, then there's an option to transition to hospice. But you can see this is could be a long journey. And I had many patients that actually, would get, quite a bit of palliative care support from me, but ultimately be cured or have very prolonged remissions. And so long, in fact, that even when I left, they're still around. And as a macabre thing, I sometimes check the obituaries and they aren't in them. So I think that's a good sign. So who would benefit from palliative care then? Anyone, neonates to adults. That's important. I've really been focusing more on adults, but there actually are pediatric palliative care physicians, there are neonatal palliative care physicians, and anyone receiving an active or disease-modifying treatment for a serious life-threatening illness would be especially appropriate to receive this type of service so that their suffering, their family suffering can be relieved. Certainly anybody with cancer, any end-stage organ disease, we've talked about heart failure, but emphysema, even stroke, if you've had a lot of strokes, can leave you very debilitated and having a lot of symptom burden and quite a lot of stress in the family. Renal failure, that when you're on dialysis, advancing neurologic diseases. We talked about Parkinson's, MS, muscular dystrophy, dementia. These are just short lists. There's like a million other reasons why palliative care might be involved. And interestingly, even patients with prolonged stays in a hospital, like in the ICU, and they're not really getting better, sometimes they'll get a palliative care consult just to figure out what's keeping them from improving, are the goals of care that they have being met. And then there are palliative care programs in nursing homes and sometimes even assisted living, and they may be appropriate for people who are really suffering from the burdens of just advancing age and sort of general illness. They're not really actively dying, but they have 10 million things wrong with them. And they're diabetic and they've had heart attacks and they have heart failure and they've had strokes. And I mean, we all know people like that, and they're in a facility, but you don't want to just park them there and not attend to their suffering, distress too, because they have it also. So when should someone see a palliative care specialist? I would say early, generally, if it's a really serious life-limiting illness like cancer that isn't stage 4 or metastasized, because almost always you're going to need to have palliative care for a long time, if not, immediately. The sooner you start, usually the better you feel for longer. So, and then if you have heart failure, then sometimes you don't access palliative care until you're in a more advanced stage of heart failure. There's no rule though about any of this. So if you feel like, your disease is getting worse and your symptoms aren't adequately, managed, or you're worried about your family, they're suffering, or you feel like your doctor just isn't talking to you the way you would like about your goals, then a palliative care referral is appropriate. Basically, my rule of thumb is if you think about it, do it. Usually that works almost everything in life. If you think about it, unless you're going to do something bad, then don't do that. But, but in the practice of medicine, if you think about it, you probably should do it. If you're a patient and you think about it, you probably should do it. Ask for help, get somebody to help you with your journey. So I don't know why I had that there, duplicate, I guess. So who provides palliative care services? Well, it's a team approach, as I mentioned. Most programs these days are physician-led, but sometimes they're nurse practitioner-led, particularly in hospitals and nursing homes. And more I'm seeing physician assistants in the field. Now, for sure, physicians have to have a board certification in a primary specialty, and then, so they have to do medical school, the residency, pass their residency boards, and then they have to do a 1-year fellowship in palliative medicine, and then they have to pass that board. Not really quite the same rigorous standards for a nurse practitioner or a PA in terms of their training. Sometimes they do 6 months, sometimes they do a year, sometimes they just kind of learn, from being around other people. And then they can take a board exam. And basically, the board exams are very similar between the specialties. So on these board exams, you have to demonstrate that you have pain and symptom management expertise for various disease states, which makes palliative medicine sort of unique in that way. Because, your primary care doctor knows, well, you've got, joint pain, back pain, things like that. They're not really trained in using opioids, using other types of drugs to manage pain, not opioid, and what kinds of pain are likely with like cancer or Parkinson's, and what are the best treatment options for those diseases without making them worse or interacting with their other drugs. You also have to demonstrate an understanding of psychosocial factors that contribute to suffering. You have to understand prognostication, still not an exact science at all, because we're really not in charge, but there are some good tools that can kind of put us in the ballpark, and that helps patients and families plan. And you have to have skills in conversations about goals of care. What is the patient is expecting? What is they're hoping for? And also in advanced care planning, which I'm not going to really focus on. And then you have to be a really good communicator, because you really have to talk to a lot of different providers, because basically as a palliative care provider, you're acting as a liaison to the physician or the other care team members. The subspecialty physician, even the primary care. And I also acted between settings, and we'll talk about that in a minute, I think. And then additional palliative care team members may include a nurse to follow up and see how is that med working? Are you having side effects? an LCSW or an MSW to deal with those psychosocial problems that you might have encountered. Sometimes they will include a psychologist, even occasionally a psychiatrist, chaplain, pharmacist to help with drug and med decisions, looking for drug interactions and optimizing treatment. Dietitians are a really big part. As disease gets worse, people, as I said, don't want to eat. And so how to kind of promote the best eating habits that we can for that patient to maintain their function and their energy. Physical therapists to help with balance and strengthening. Occupational therapists to promote people being able to maintain their dignity by still being able to do their activities of daily living, like bathing and dressing, and tools. Like if you have Parkinson's, you have the tremor. There's special tools you can use so that you can feed yourself, and not have to rely on other people doing that. Speech therapists to work on swallowing problems that someone might have, or speech. And then, like even in my practice, we had ancillary sorts of services to other healing modalities like acupuncture, massage, meditation, mindfulness therapy, music therapy, art therapy. Those latter two are really common in the pediatric palliative care world because that's very healing to children. Probably is to adults too, but most of those people seem to want to focus on kids. And then where are these services delivered? Well, some of them are delivered in freestanding clinics. That was I always had not always, but I had the luxury of doing that for much of my career. So I was involved in an inpatient palliative care team. We got that started actually, another doctor and myself at a big hospital. And we did that for a couple of years, then shifted into more time in the heart failure clinic where I worked one-on-one with people in various stages of heart failure, and then got invited to join an oncology practice as their embedded palliative care specialist in the oncology clinic. It was a big practice and they had satellite offices all over, but everybody pipelined their patients to me. But it was a wonderful experience because we were all part of the same practice. So it was very easy to communicate with any one of them. And I was surrounded by oncologists in the clinic I was in as it was. So made for very cohesive care for the patient and for the physician too, the oncologist. It can be delivered in the hospital, as I mentioned, inpatient palliative care programs, the nursing facilities, assisted living. And then there are more and more these days, some home-based palliative care programs, and I'll talk about what's available locally in a minute. And I think those are kind of useful too, because if you're really feeling, weak and tired and having pain, if you could just stay home and have someone come to you, a provider, a physician, a nurse practitioner, boy, that's pretty nice. That really saves your energy for things you really want to do instead of going to the doctor's office. So I'm just going to outline quickly what a palliative care visit looks like. So first you would meet with a treating clinician, which would be the doctor, the NP or PA, and they would discuss your understanding of the illness and its treatment and what you're hoping for. Now that seems kind of like, well, of course they know what they're hoping for, but a lot of people haven't really expressed that. And it's kind of interesting because, most people do want to live, but that's not always what they're telling you they're hoping for. They may tell you they're hoping they can get better so they can ride their horse again, or so they can drive their PT Cruiser. I had one lady who wanted to do that. Well, okay, let's see what we can do about that. It meant no narcotics, so she's going to drive that thing around. But, it's just, you really want to know what their goals are. And then the clinician should be listening to your story very carefully and your concerns, so they do glean what is important to you. So we're making sure our treatment plan aligns with your goals. A good example is maybe someone has a wedding, and they want to go to that wedding. Well, that's probably it's probably best not to start a whole new kind of chemotherapy 2 weeks before the wedding. But if you never ask them that, then that could happen, because very rarely is a patient going to tell the oncologist, no, I don't want to start that chemo. I know my cancer's getting worse, but I don't want to start that. They're going to go, okay, I'll start it. And I'm going, no, they got a wedding. 2 weeks isn't going to make any difference. And then the oncologist can say, all right, you go to the wedding. When you get back, we'll start this new chemo. Everybody's happier. me too. So, and then that clinician will be addressing your pain and symptoms, trying to optimize the treatment, hopefully with the least number of medications. That was always my goal, is to reduce polypharmacy. It was always distressing to see people come in and their med list was practically a book. I mean, single spaced, 20 lines down. I'm going, oh my gosh, how do you manage to take all of these? No wonder they're not hungry. I mean, filled up with pills. So, and then you can add additional support services as needed to address those other symptoms of distress. And I think that sort of covers that. So this is a little case study, kind of sad but true. Not this person's name, but she was 30 years old and she was a single mother of a 2-year-old who had metastatic melanoma when she was diagnosed at 30. She was seeing her oncologist who was giving her chemotherapy, and she just had so many symptoms. She was so stressed out. He said, Jane, you need to do something for her. I said, okay. And so I saw her and I met with her, and her understanding of the illness, though she knew it was metastatic, she didn't seem to understand that metastatic melanoma was not curable at that point in time. This was 10 years ago. And her goal was to fight the cancer and beat it because she was going to be around for that 2-year-old son. But I didn't argue with her. You don't say, no, that's unrealistic. You go, okay, so I understand that's your goal. Her main problems were really severe fatigue. It was really hard. And she was nauseous all the time from the chemo, despite being given lots of anti-nausea medicines for her chemo. And this is just as a demonstration, like, it's not like oncologists don't know how to manage chemo-related nausea. They surely do. But sometimes even with all the meds you have, it doesn't fix it, all their usual meds. So I always had some tricks up my sleeve. And she wanted to be able to spend more time with her son and doing more things. And the fatigue and the nausea at that point were really interfering with her ability to care for her toddler. And I actually think it was also making her sort of irritable. And a toddler is kind of irritating anyway. I mean, you love them, but they're always doing things and you don't want to running around and you think you're going to throw up. I mean, it sounds pretty awful to me. So she also expressed a lot of anger and frustration at being in this situation. She was completely overwhelmed. She had to quit her job, so her finances were terrible. And so, like, whoa, that's what I mean, all these hats. I'm thinking, wow, what am I going to do with this? So I started her on a drug, dexamethasone, which is a steroid, not a drug that normally the oncologists use it a lot, but they hadn't thought about using it for her. And a primary care doctor would probably never prescribe it under these circumstances, because her oncologist sat like right there in that chair next to me. I said, hey, Greg, do you mind if I put her on dexamethasone? No. So within, a week, her energy was better. The nausea was gone. She was really feeling pretty good. The chemo was starting to work. She was still kind of emotionally distraught. Some of that might have been a little bit of the steroids, but I think it was also her disease. So I had the luxury of having a palliative care social worker in the clinic, and I sent her to him. He was doing some guided imagery and some cognitive behavioral therapy too with her to help her cope with the stress of her illness and stress of being a parent. And really the social worker is much better prepared to help people connect with community resources. So in her case, it could get her food assistance. The American Cancer Society, I learned this, I always learn a lot from other people. So I enjoy that, which is why I like the HASP classes too. But the American Cancer Society provides rides to treatment. They'll pay for it. So the social worker got her hooked up with that. They worked, she did have family. It wasn't like she was totally alone, but she didn't want to bother them. They were working. So the social worker worked with her family to coordinate some childcare. So she didn't have to bring the 2-year-old to her chemo treatments, which was hard for her and sort of disruptive to the clinic because we were not a pediatric clinic. And we didn't want to tell her, no, don't bring them. But we got IV poles everywhere. Now you got a 2-year-old running around in the midst of that. So yeah, I like the laugh. Like, what could possibly go wrong? And then it turned out, and I don't know that I had this, well, she was also pretty angry at God for allowing this to happen. And that was causing her to, sort of question her LDS faith. And I'm not LDS, and I don't know how many people in here are, but LDS faith leaders are basically members of their church. They don't have a lot of advanced training and chaplaincy or things like that. Not to minimize what they can do, but she didn't feel comfortable talking to her bishop about her anger at God. And I think some of that even comes from she didn't want it to get out to the rest of her LDS community that she was mad at God, because that doesn't look too good, right? So that social worker hooked her up with a chaplain who could talk to her. It was non-denominational, as most chaplains are in palliative medicine. So they're not coming in with an agenda. They're just helping you process your feelings about your faith and what's happened to you. And really that actually got a lot better with time, which was good. And then another reason why you really talk to your patients, her mother was a breast cancer survivor herself. And her mother really felt guilty that her daughter had this metastatic melanoma and wondered if there was any connection between her breast cancer and her daughter's melanoma. And in retrospect, maybe there was, but we didn't talk about that. But we did get the mother set up with the social worker too, to talk about her emotions, because it's a family affair at this point. And she actually had a really good response to chemo, and she never really had much pain, thank goodness, at first. Nausea, fatigue got better. She actually had enough energy that she could volunteer at her son's nursery school. That made her really happy, so some of her goals were revolving around caring for her son. Unfortunately, about a year later, she developed really bad back pain, and I ordered an MRI that showed metastatic disease to the spine, and it was in a location that if it grew any larger would probably render her paralyzed from the waist down, and that would be catastrophic to a young mother, to anybody really, but especially in her case. So I started her on dexamethasone, talked to the oncologist, set her up with radiation oncology, and they did just a short course of radiation, and that controlled the cancer in that spot. And she met with the oncologist, and she pretty much exhausted the standard treatments, but they had an experimental one they thought she could try, but she was worried about that because she didn't know what the side effects would be. Frankly, we only could imagine. We didn't know either, because clinical trials are sometimes like that. And she actually had come to realize by that point, through lots of conversations with me and her oncologist, she now knew this was not curable. And ultimately, she decided to proceed with treatment. Unfortunately, the treatment didn't control her cancer. And her oncologist advised her that there was no more cancer treatments available for her melanoma at that point. That was pre-immunotherapy. And he told her that he thought she might have 6 months. And I got a phone call. She was in a panic, frightened. There was often nothing left to do, common thing to hear, nothing left to do. And I said, well, BJ, that's not really true. Here's what we're going to do. We're going to have hospice come out and meet with you. So she's been in palliative care, getting palliative treatment for months and months and months. I think it was 18 months in all. And we never really talked about hospice to any degree at all, because it just wasn't consistent with her goals. And we weren't trying to be avoidant. We were trying to help her enjoy the quality of life she had while she had it. And so I talked to her about the hospice team and what they would do and how they would support her comfort and her function and how it would support her family. And she agreed to go on hospice, and she did go on hospice, and she died on hospice. And I'm not going to get into that whole thing, but it was, for a 30-year-old woman with a 2-year-old, it was a pretty good death, not an easy death, but she didn't suffer a lot. Her family was all with her. All ducks were in a row. She arranged for the custody of her 2-year-old son to go be with her sister. So, this was really important work that needed to be done. So that's kind of an example about how palliative care can work. So it's not hospice. It can be a conduit to hospice, but I would say many of the patients I cared for never ended up on hospice. And they didn't die in the hospital either. They just lived. They were still living. we had them on meds to keep them comfortable, to let them function, enjoy their life, and they were doing fine. So it's not always a conduit to hospice, but it can be. And it's nice when you've got somebody there to hold your hand and pass you off. And I think my oncologist really grew a lot with me being there, not to blow my own horn, but they just learned different ways of dealing with these challenging problems. So the palliative care team's focus, as we've talked about, is to manage the patient's pain and symptoms, relieve their psychological and social distress, using that multidisciplinary approach, helping the patient and family understand the plan of care, which is also a big issue, as we've talked about, helping them navigate all the complexities of this system. Where do I go? Helping coordinate care, providing practical and emotional support for the caregivers who often are just beyond stressed, and then really focusing on maintaining or improving, if possible, that patient and family's quality of life. And does it work? Yeah, there's studies that actually show it works. People do have less pain, less other symptoms. They are more satisfied with their care. They do feel like their quality of life is better. Their caregivers' feedback is very positive. Even the physician feedback is usually positive because it's taken a load off the physician in a strange way. They're kind of grateful for that. And the interesting thing here about this is that it actually helps people stay on their life-prolonging treatment, which a lot of people didn't expect that to be the case. And that's been a real good selling point to get people to go on palliative care. Because think about it, if your pain and symptoms are managed, you probably can cope with your treatment better, right? And you're not going to have accidents and falls and break bones that throw you off course. So really, people stayed on the longer people stayed on palliative, well, the earlier people got on palliative care, concurrent with their disease management treatment, the longer they lived. And that especially is true with lung cancer, by the way, really good data on that one. So how do you personally access palliative care? Well, this is how it's different. In Utah, you could refer yourself, but in Michigan, you have to have a doctor send you to a palliative care program. So it could be your primary care doctor, it could be your specialist, your cardiologist, or your oncologist, and you just have to ask, can I have a palliative care consult? Hopefully they would volunteer that, suggest that for you, but if they don't, you can ask. In town here, I did discover there is one home-based palliative care program. It's called Keystone. They used to have an outpatient clinic, a freestanding clinic, but they closed that during COVID and they haven't reopened. So what they do is if they get a referral for a patient with cancer, heart failure, Parkinson's, dementia, whatever, they send one of their doctors and or nurse practitioners, and they have several, I think maybe 6. And they'll come out to your home and see you there. And generally, they'll see you within a couple days of the referral. So you don't have to wait a really long time, which is kind of nice. And then they'll just regularly follow up with you. And they may initiate home health. So you might have a home health nurse coming in to kind of supplement what they started. They do have social workers and chaplains that work with them too. So they might come in and visit if that's deemed necessary. So that's kind of nice. And that's here in Ottawa County. And they do service Allegan, I think. No, I know that to be true. And then Corewell, formerly known as Spectrum. I hope they stop renaming all these healthcare systems here. It's kind of confusing for a newbie, but anyway, they actually have embedded, like I was embedded, which means palliative care specialists in clinics. So they have palliative care specialists in their outpatient oncology clinic. They happen to call that one supportive care and integrative care. I didn't say this, but interestingly, in my clinic, they also want to call me a supportive care specialist because I don't know, oncologists are freaked out by words that sound like dying, I guess. I don't know why they thought palliative meant dying, but I could never convince them. They want to call it, supportive care, fine. If you like that, it's okay with me. And so they call it supportive and integrative care, which integrative suggests to me they probably do have other modalities. I didn't ask them that, but I suspect they have massage and acupuncture and things, which, by the way, has some good indication, acupuncture and massage and even meditative therapy for cancer symptom management. And then they also have an embedded specialist in their heart failure clinic at Spectrum. I don't remember what the name of it was, and they have a home-based palliative care program too. And then Trinity has embedded palliative care services at the LAC Cancer Center. And they also have one, I believe, I didn't put this on here, but I wrote down that they have one in their neurodegenerative clinic. But I didn't call that clinic to find out what they do. But that's what they told me. So anyway, and then most hospitals have an inpatient palliative care team. It's a requirement for sort of certification. And then let's see, inpatient PC, and then some nursing homes. And we kind of talked about that. And then if you want to find somebody some other way, or you have a family member you'd like to get hooked up, if you go to this website and type in their zip code, and then wherever they are they in a hospital? Are they at home? Are they, in an assisted living? You can put in the zip code and then the location where they'd receive the services in one of those facilities. And it'll pull up a bunch of doctors that are board certified in hospice palliative medicine. I don't think that'll give you nurse practitioners because I believe this is just a physician directory. Okay. And is this paid for? This sounds too good to be true, so it can't be paid for, right? Well, it is. That's the good news. And there is no time limit. So Medicare Part B will pay for it. I mean, you have to make your applicable co-pays, unless you got a secondary. Medicare managed care plans, so the Med Advantage plans, they'll pay for it. In fact, sometimes they even have their own palliative care team as part of their insurance company, which I think is a little dicey. I don't know. I haven't been super happy when I've had interactions with those people, because I think insurance companies have a different agenda than I might. But that's just me saying. So I don't know. They probably wouldn't agree with me. Medicaid does cover palliative care services, and most private insurances will too, because it's really basically a doctor visit. And so you do have co-pays, but you get to see the doctor for your palliative care needs. And there's not a time limit. You could be on palliative care for 1 year to 13 years or 20 years or however long you need it. And we do try to get people, back to they always go back to their primary care, because I don't manage their hypertension and their other things now that they've gotten through their cancer therapy. But I might have, like a lot of people I saw the whole 13 years I was there, because they still had neuropathy from their chemo, and their primary care doctor didn't want to deal with it. And sometimes primary care doctors don't like to write narcotics, especially these days. And when you're palliative, you don't have the same, you have to follow the same rules, but you're pretty experienced with it. So it's not, limiting. So we're just about done, I'm happy to say. So this is sort of a summary slide of what palliative care is. So it's for people, hopefully, in part of this information, people who are facing a serious or life-limiting illness of any age, and it's provided concurrently with active treatment of their disease or illness. That's the whole contrast between it and hospice. Hospice, you're not getting treatment. Some rare exceptions, but I'm not going to get into that. But basically, that's the distinction. You want to continue your treatment, then you want palliative medicine. And it includes all of the things that would palliate your pain, your symptoms, services to help you with psychosocial, social, and other spiritual distress and suffering, support for your family. They help you provide transitions in care settings. If you're in the, you've been seeing the oncologist in clinic and you end up in the hospital and now you're in a nursing home, it's often the palliative care person who's calling the hospitalist. Oncologists will too, but you want to make sure they know what you've been doing. I have been doing for you as a patient, so they continue and don't make you suffer. And then I have to call the nursing home or the rehab facility medical director and talk to them and tell them, this is what we've been doing. Please don't stop it. It works, and then if they see a PCP, I have to communicate with them. And then I'm always happy when they come back and they're doing exactly what I suggested, because usually then the patient's happy. And once in a while, the doctors still will change their meds, and I'll get a call from the patient from the rehab facility and I'll go, ring, ring. We'll get it fixed, but you need to have that liaison there to help you in those transitions and to back you up. And through that journey, then we have those conversations about goals of care and where do you think this is going and what do you want and what's important to you. And really the top priority of the palliative care team is to optimize that patient and their family's quality of life throughout their healthcare journey. So we want to help them live as fully as they can for as long as they can. And that's what we do. So there. And I didn't see anybody actually fall asleep. I saw some eyes closed, but that's okay. They came open. So I'm glad I didn't bore anybody to death. And we have some questions.
We have a question from online. Which local palliative care service would you recommend for an individual with Lewy body dementia?
Well, if they're in Ottawa County, from what I understand, I think that Keystone might be a good choice for them for palliative. And there is a time when somebody with Lewy body dementia might even be eligible for hospice, but they usually have to be in a pretty advanced stage. And dementias can be a very slowly unfolding process. But I would really suggest a palliative care consult with Keystone. And I think they'd be really happy because actually I've taken care, we didn't mention that, but I worked in a dementia clinic for a year or two. And that was kind of eye-opening, but Lewy body dementia is especially a challenging dementia. And they have lots of needs and it's pretty hard on caregivers. So that would be a good resource and they could probably help with aids and other things. That's where social workers is great too, because I don't know what the community resources here are in Ottawa County. I know what they were in Salt Lake County, but a lot of counties will have a council on aging, within the county, and they'll have services that they can provide, including like volunteer caregiver, volunteers to come out to the home so you can personally have a break. Because I see, particularly with elderly couples, and women, and especially, we feel so obligated to take care of, to be a caregiver and to take care of our man or our mother or whoever, that we really get quite burned out. And when you're burned out, then sometimes you're not really doing yourself any favors, maybe not even the person you're caring for if you're getting angry about it. So accessing these services so you can get a break is really important. And it is really, really important as a caregiver to take breaks. You just can't do it 24/7, even though that's the requirement. You feel like that's a requirement. Has anybody read The 36-Hour Day? Yeah, it's a good book about dementia. It is what it sounds like. Sorry, yeah.
In the final care of a patient, could you speak to the practice of withholding food, particularly for long?
Yeah. So in palliative medicine, that doesn't come up because people are usually trying to maintain their nutrition. So they're trying to eat. But on hospice, it's a very different situation. And really in the last months of life, people do lose their appetite. It's a very complex process of why they lose their appetite, but it's an interesting thing because almost nothing is very successful in overcoming that. Sometimes you can give people medicines that make them hungry and they'll eat a little better, but it won't last very long. And it probably has to do with the cancer metabolism. So here's a funny thing about that. So if you're sick and you're dying and you don't want to eat and you're forced to eat, you may feel sick and throw up. But interestingly, even if we feed people artificially, if we put them on a tube feeding, with cancer anyway, put them on a tube feeding or put them on IV nutrition, they'll still lose weight, even though they're getting enough calories, because the cancer itself is putting out a metabolite that prevents you from using the nutrient in a way that helps your body. Now, whether it's helping the cancer or not, nobody knows. But generally, it's not recommended that you force people to eat, which is very hard for people to watch, and I tell, I'll have a woman come in and I made him his favorite thing and he took 2 bites and he was done. And I said, well, good for you for making his favorite thing. And he had 2 bites. You have to be happy with little successes. And another one that does come up, and I don't know if you're alluding to dementia patients, but people with very advanced dementia often stop eating, and you can feed them, manually, and some people do, but eventually they'll stop eating like that too. And it's pretty clear that tube feeding those patients does not prolong their life in a meaningful way. They don't get better. They're not going to recover from dementia. They usually won't gain much weight, but because they're bed bound and you're putting all this extra fluid in them, they have more trouble with fluid retention and bed sores, and it doesn't really serve what you think it would. Even people that have trouble swallowing, and I always would get in these little tit for tat things with speech therapists, because they go, well, they can't eat, they should be tube fed. And I'm going, why? They want to eat. So what if they aspirate? Let them eat. They don't. In fact, they almost never do aspirate, once in a while, but then they cough. So it's got to be what the goals are, what the patient's comfortable with. Having a tube down your nose is not a pleasant thing at all, and having it, you can put it directly in the stomach, but it's not really a ton better. Does that kind of answer your question? Yeah.
There's a lot of coordination that's required here. I can see with multiple patients that you see all day long, and all these people that you have to keep track of and all that. A, how do you manage that? And B, is there an opportunity for what we're hearing with artificial intelligence to kind of help the palliative position?
That's a really good question. I haven't really thought about how AI could have helped me in my life. I can tell you computers made my life really miserable. Because I hated EMRs. I really prefer writing notes. And though my handwriting isn't beautiful, it's legible, but it was always way faster and I could be way more engaged with patients. So I spent a lot of time charting. But how did I keep track of it all? One of the nice things about being embedded in a clinic with specialists is that their expectations for you are really different than they are for themselves. So an oncologist probably sees a patient every 15 minutes because remember, they're disease focused. You have cancer. This is what we're going to do. And then in 6 weeks, this is what we're going to do. And if this is that, then we're going to go to that. Okay. They can do that in 15 minutes. And, they do ask, oh, how you doing? Everything okay? All right. You'll be sure to follow up the chain. And then they would see me. And I typically had, for a new patient, visit an hour and a half with a new patient. And then I would have 30 to 40 minutes with anybody that was in for a follow-up. Pretty luxurious by doctor standards. So I would only see 12 people a day, depending on how many new patients I saw. And after a while, I did get a little kind of overwhelmed, to be honest. And they did hire a nurse practitioner, which was a godsend. And that helped a lot too. So we shared, and that was kind of nice to be able to share more. And then you, if you can, you get, home health involved, and then you got those people reporting to you too, which is another mechanism. And just one more thing about, this wasn't AI, but it was computer. There was a movement, it didn't actually fully develop, where they were having cancer patients have iPads in their home, and then every day they were supposed to fill out this questionnaire so you could see how they were doing. And that actually was kind of helpful. So you had better real-time knowledge of how things were going, rather than not. I would see patients fairly often too, like every couple of weeks. So but if you wait 2 weeks or 4 weeks, that's a long time to go without me knowing if this is working, right? And so that was kind of a useful tool. Yes.
Well, first of all, thank you for taking all that time, an hour and a half, unbelievable. Do you, when a patient comes involved in palliative care, do you initially see a physician, given the fact of how many are in practice today with palliative care? Or sometimes we know we go to the clinic, we see the physician's assistant first, like even if you go to cardiology, sometimes you see that person first, he makes the initial assessment, and then of course he collaborates with the cardiologist. So I wonder, in palliative care, is there always a physician as part of the team, or could you singly be with a nurse practitioner? In some states, that's probably how it works. I know I have relatives in Oregon and they see a nurse practitioner. She has a full office and everything. They don't see the doctor, but Michigan, It could
Yeah,
be
it's-
different.
It is different state to state. That's a really good question. Initially, when I got a nurse practitioner, I still saw the new patients too. She would, in our practice model in Utah was that the nurse practitioner would go in and get the initial history, and then the doctor would come in and see the patient. So we always had contact with them. But after a while, if they're just coming in for follow-up, I would just let my NP do that. I wouldn't see him all the time. And sometimes they'd actually, I'd have them scheduled to follow up with me, and then they'd go off and see her, and I'd go, hey, how come you're not coming to see me anymore? They go, well, we really like Amy. She's doing a good job. Oh, okay, fine. I don't need to control everything. It helps me have time, right? So it's a little different model. I think this is one of those things where patients should feel free to speak up and say, I would really prefer my visits to be with the doctor, or at least every other one be with the doctor. Because that really can happen, and you really do have the right to have that happen. Nurse practitioners are very good, and I think a lot of situations they practice very independently. In Utah, they could have their own clinics, but they still needed to have a supervising physician out there somewhere. Yeah, but yes, I agree. And I did have to sign off in Utah anyway. I had to sign off on all my NP's charts. So I always had her note I would look at before I signed off. So I kind of knew what was going on because I did all the call, she didn't. So I wanted to know what was going on because if I got that call, I wanted to know. So, but different ways in different communities. That's why I said I haven't really accessed much care here. And I don't know if there's any interest, but maybe another time I could do one on hospice, because I think hospice is a little not like what it is in Utah. And I was surprised by that because Michigan was one of the forefronters for hospice care when I was a resident. And I just have been kind of a little bit like, why don't they do that? I don't understand. So I don't know. It's covered by the hospice Medicare benefit, but they don't always get all the services I think they possibly could. So might just be staffing too, Yeah. With COVID. I moved here June of 2020, so it wasn't a great time to be here. And then I had a relative who ended up on hospice, and it was a really odd experience for me, but no, go ahead. Well, and we could send this out, or at least the last slide and the slide with the contact information. I don't have any.
This
it's not
will also
required.
appear on the HASP YouTube channel.
Oh, yeah, that's true.
At the end of this semester, it'll be available.
Okay.
So you can watch it again.
Yeah, if you want. Did you have a question? Okay. Yeah, okay, good. Any other questions, or you've got a very nice audience?
I have one.
Yeah,
In your career, did you very often have to deal with a non-compliant patient, or worse than that, a non-compliant family of a patient? And if so, how did you cope with it?
well, it's a pretty common theme, really. And, non-compliance is a funny thing because it sounds pretty negative. I always had to be careful when I put that in charts, especially now that people can read their charts. Non-compliant, what are you talking about? I'm a very compliant person. I'm well, not by my definition, but usually if people aren't doing what you kind of suggested, there's a reason, and so you need to understand, and that's back to the goals of care. What is the problem here? And sometimes I had this guy really early in practice, kept ending up in the emergency room all the time. And I finally decided he had heart failure. So he kept ending up in the emergency room, and I went to his house. I said, okay, I'll make a house call because it was pretty hard for him to get in. And they were lovely people. And I showed up, I guess, at their lunchtime, which I hadn't planned on doing. So I was invited to lunch, and they had soup, which was not low sodium. And then after lunch, they always have a bowl of popcorn with salt. And I said, well, okay, now I know why you're always in the emergency room. It wasn't like he was non-compliant with the medication. He was non-compliant with the diet. And honestly, as a physician, I felt like it was wrong. I mean, he was like 80 some years old. So for me to tell him, you can't eat that popcorn anymore. I'm sorry. It was just ridiculous, you know? And so I said, well, how many days do you have this popcorn? Every day? He said, well, just about. And I said, okay, so here's what I want you to do. And could you? And I told his wife, on the days you're going to have popcorn, I want you to take an extra dose of your Lasix. Never was in the ER again. And he didn't have to give up his popcorn. And then you do encounter people where they have a very chaotic lifestyle. I don't know if you've encountered that, but it's just chaos all the time. And they really they haven't had the skill sets to follow any direction probably their entire life, you know, and it's not going to get better just because I'm involved. So I write out a lot of directions for them and hope for the best, send in home care. And then you have the people that don't want to follow your directions. Doesn't matter. They don't believe you. They don't trust you. They don't want to hear it. I don't know, but they're just not going to do it. And you just have to accept that and not get super mad about it. And then I guess I became more aware of this as I was in my career longer, but then there's the other social determinants of health. And I remember very vividly that there was a patient, she kept going in and out of the hospital, and the PA was seeing her in the hospital, and he came over to the clinic to talk to me about her. He says, gosh, I just sent her home 2 days ago and she's back already. So I went over and talked to her. Well, he sent her out with a list of meds she couldn't afford. Her insurance, she was in this sort of weird insurance program where they would pay for 5 prescriptions a month. And he had written her for 8, you know, I don't know, something like that. And she had to pick and choose, and she just didn't pick what he would have preferred, but he didn't know that she was on that program. So it wasn't really a deliberate noncompliance. It was a social situation that prohibited her from getting the meds. So we looked at what did she really need? What would keep her out of the hospital? Could we get them cheaper somehow? Like Walmart has $4 meds because she could scrape up $4, but this plan, she didn't think about that. A lot of people don't. That's one of the jobs we're paid to do the thinking. And I said, well, you know, I know this program you have will pay for 5, but could you afford $4 if you could buy it over here at Walmart for $4? Well, I could. So we sent those prescriptions there for the $4 benefit. I mean, lots of thinking.
Question online.
Oh, yeah.
Yeah. Did you have any experience?
This
With
question
that.
is from Judy, and she will unmute and ask her question.
Sure.
Hi, I'm Judy Zeilman. I was the director for hospice in Holland here for 24 years. And retired in 2007, and we had started a palliative care program in the early 200s there. Totally, your presentation was. Can you hear me? Can you hear me? Oh, so anyway, so palliative care has become very
Judy
more.
is trying to ask her question, but it's not coming through right now.
Oh, really?
Technology. This is why
Can you hear me?
not sure about AI.
Judy, could you start over again?
Okay. I'm Judy Zeilman. I was the executive director for Hospice of Holland between 1984 and 2007.
Okay.
And we have a wonderful program here in Holland. And we started a palliative care program
Right.
in the early 2000s. But at that point, it was mainly physician driven, and hospice covered all the costs of it. And so that was quite interesting to me for you to have such a complete program of different disciplines that are available, and especially that they're all paid for. You said there could be co-pays. So are each discipline separately co-paid by your insurance, or how does that happen?
Well, that's a really good point. And so, yes, I mean, sometimes, no insurance will pay for chaplain support. So somebody else has to underwrite that, right? And that's, I believe, why, especially here, I'm seeing a lot of marriages. Almost all the palliative care programs I reached out to were actually part of a hospice, which that's not really the norm in Utah, but it is the norm here. But I can see why, because then you have a chaplain on staff. Now, I was affiliated with a large private oncology group, and oncologists even today make they have a pretty good income stream. So they would underwrite some of this. We had a social worker, an LCSW, so he could bill for visits. And yes, there could be a copay for that. But generally, I think my understanding was they actually just salaried him and paid. And I think he very rarely billed. But you see, oncologists, and this is something people don't think about, oncologists, cardiologists, they're busy people. Having palliative care really takes a load off their plate. And frankly, we add to good outcomes for them because we help their patients do their treatment. So they were willing to underwrite a lot of this cost. But my visits, my nurse practitioner visits, were always billed to insurance because we billed everything else to Medicare. So we had to bill. I didn't really, people liked seeing me. We really just didn't have a lot of problems, problems with people and the copays, because I think they felt like they were getting good value for their copay. So,
Okay.
And by the way, I think insurance coverage is much better in Michigan for people than it is in Utah, which is a little odd too. Just different practice, different insurances. So, yeah.
I'm not sure about the Keystone program. That's been separated from hospice, but it's in the same building that the hospice office is in.
Well,
It's upstairs there.
yeah, I just talked to the gal at Hospice of Holland last week about the situation, because I'd heard from another doctor about it, and they're still running independent. And
Okay.
I think that the hospice team does provide the social work and the chaplain to go out, and they probably pay for it, but I didn't ask her that question. I know that the practitioners bill when they make house calls. And Medicare, by the way, will
For some reason, you're muted.
I think we all got muted. Everyone is muted, even the presenter.
No,
It's on my screen. Yeah.
okay. So there was a lot of family support. The people of the LDS faith, it's a very nuclear group of people. So the families tend to stay together. A lot of them don't leave Utah. And so they had tremendous support. They also had a lot of support from their ward, but like anybody in any neighborhood or perhaps in any church, there's a certain amount of busybodies out there, and so that was the concern for my 30-year-old patient. She really didn't want them in her business. She wanted her medical life to be private. So you always have to be careful with that. I've never, ever reach out to the bishop myself. I would let the patient do that because that was really their decision to do that. And if they wanted chaplain support, then we went a different way. And yeah, then I would have to rely on the hospital chaplains. And since, even though I wasn't like part of the Intermountain Healthcare, they did have a chaplain presence, and so did another big healthcare provider out there. And so we could access them. Other questions or? I appreciate Judy speaking up because, yeah, I didn't go that far back on the history of their palliative care program here.
Yeah, she's very good.
Yeah.
When you have your meetings with the patient, you at times also have family conferences. So is the patient allowed to bring like his
Oh.
4 brothers and sisters?
Yeah.
Because that can really get to be an issue when people have but you do,
Yeah.
that's part of it.
Sure,
Not
it
all the
is.
time, but there might be where you're
mean,
initially meeting.
In our oncology clinic, we always encourage them to come with someone because, they kind of have chemo brain. You need another set of eyes and ears. But it was fairly common to have very big family meetings, particularly me. And, I could accommodate maybe 8 people in a room with the patient myself. Got a little hot, cozy. But I tried to do that just because it's a team effort, and you need to have everybody on the same page. That was also why I often ran very far behind schedules. So if you see a palliative care doctor, please be patient with them because every time we walk into a room, it can be almost every time it can be complicated, and it's like, oh my goodness. Okay. And they brought in Uncle Fred, who doesn't understand why they're not doing this, that, and the other thing. And so you have to kind of hold his hand and understand what his worries are. And otherwise, the whole treatment plan is going to get sabotaged by one person, and he probably doesn't mean to sabotage, he just understand. Yeah, pretty labor intensive. I always thought if I was going to do a second degree, I should get it in what do you call that? Negotiating, the wisest social worker I ever met told me about this Indian method. We had a lot of Native Americans out there, and she told me about this Indian method where you get the stick and it's your turn to speak. So I would have lots of family conferences where I would say, you don't have the stick, so you have to be quiet until it's your turn. It's like, okay. Very fun. It was kind of really fun because when you finally end up being done, I can outlisten them, and then they all end up fairly satisfied, which is kind of gratifying, really. It might have been an hour and a half later, but yeah, that they've been listened to, right? So, yep.
Did you have any experience with ALS patients?
Yeah, for sure. Is that from home somewhere?
Yeah, any difference there?
Was it different there? Well, I guess it depends on what you mean by different. One of the things that the problem is that for ALS people, a lot of their treatments that they may need, depending on age and goals, might be something that like a hospice wouldn't really take on, depending on the age of the patient and their goals. I mean, if they're wanting to be on a ventilator, a lot of hospices aren't comfortable managing people on vents, which I totally get. So they might be better served to be on palliative care. Some elderly people with ALS, I've had patients who had ALS start in their 80s, kind of unusual, but it can. And then their needs are sort of different. They're not likely to want to be on a vent, and have that burden of treatment. And so you have to take a different approach in managing them. And they're often better served by being on hospice. And I wasn't going to talk about hospice, but in this instance, hospice no longer has a deadline. You don't have to be dead in 6 months. I mean, there's no requirement. If you're on hospice and the doctor reasonably believes you could be in your last 6 months of life, that benefit can be renewed and renewed and renewed. Even if now it's a year later and you're still saying, well, I really think they only have 6 months.
Is that in every state? Because
Yeah.
I had read that it's either 6 months or 12 months, depending on state. It is now universal.
Unlimited recertifications. However, the doctor has to go out and see you, which is, different than it used to be. I always did when I would be when I worked as a hospice medical director quite a bit, and I would always go out and see the patients anyway. So it wasn't any problem for me. But some hospices never sent the doctor out. I don't know. Was it like that here, or did the doctors go see him at home? Or you weren't a hospice nurse, so it's Judy that was. Yeah, but no, it's not you could stay on as long as you need to stay on. And ALS is a tough one to predict how fast it's going to go. So are dementia and, Parkinson's and diseases like that. Even heart failure, sort of like I never talk about prognostication, very fluttering process with heart failure. They could go a long time. They could be dead tomorrow. It's just how heart failure goes, Only oncology cancer patients are more predictable. Other
I
questions?
can answer that question. This is Judy again. I can answer
Oh.
that question. I can
Yeah.
answer that question on recertification.
Yeah,
After 6 months, every 2 months, it was
Yeah.
that the doctor had to certify, but in our program, we only had to have a doctor recertification. I don't remember people having to have a doctor go out to their home or out to see the patient.
right.
It
And
was,
that
it
just,
was the
that,
team that could recertify them.
exactly, but that has changed and the doctor now must visit.
Oh, okay. That's
And that,
very
that,
possible in the last 15 years.
yeah, I can't remember if it's been 5 years, so 10,
Okay.
no, 5 probably. Newer.
I think it's time to wrap this up.
I'm good.
Thank you, Dr. MacPherson. It was a
Thank you.
great
Thank you.
presentation.